Well, hello all and welcome. Today we're going to be talking about urgent dental, medical, and surgical management of the infected patient. And these are interesting patients that present to our practice, oftentimes at inopportune times at the end of our day or Friday afternoon. And many times it's a new patient to our practice, so it does give us an opportunity to make a very positive impact on that patient to alleviate their pain and discomfort and then convert them into a member of our treatment family. I do want to thank Perel Pharma, who manufacture Orablock, which is a formulation of Articaine, and not all Articaines are manufactured the same, and I recommend suggest that you look into their website and into their product and formulation, and appreciate that. And interestingly, we were just talking earlier, this is Viva Learning has been going on for about 10, 12, maybe 14 years now, and who knew this would be the way of the world, that we would be learning remotely in this fashion. So let's step back a little bit and see these patients as they may present themselves into our practices. And what we have to do as a dental provider is determine, is this a mild infection, something that I can maybe treat with some localized incision and drainage, or perhaps starting on an antibiotic? Is it something more significant where there's concern that if it gets worse, that the patient may have very severe outcomes? Or is it already to the point where it is life-threatening and the patient needs urgent referral to either an oral surgeon that takes care of these patients, or more likely a hospital emergency department that has a dental team on staff? So first off, the non-serious infections, this can be extremely painful, but it's a very localized response. The body is walling off the infection quite well. I think we can all see most likely it's the source is the upper carious molar, which has become abscessed and infected. And indeed, this can be extremely painful. You can imagine the discomfort of having the palatal tissues distended to this amount, and one that we can easily alleviate for the patient with an incision and allowing it to then drain. But in general, not a very serious problem, although it may be extremely problematic and painful to the patient. So in general, non-serious infections involve healthy patients. So not only do we need to do the dental diagnosis, but we also need to understand the health history of the patient that's involved. We also want to see that the space is clearly defined. And so this is obviously a palatal space infection. We sometimes see the vestibular area swell, so we call it a vestibular space infection. And also that we have a clearly identified source. So we can see the issue is most likely, almost certainly, without the benefit of radiographs, that carious first molar. And if we can treat that, whether it's endodontic or extraction, we can eliminate the source of the infection and then get the patient on the road to recovery and recuperation. Now, infections will want to track. The body will produce pus, and that's basically collections of white blood cells being called to the scene to fight off the infection. We can typically see by the area of swelling, the tooth that is most likely the offending tooth that's causing the problem. You can see on the upper right here on the palatal side, you have the thin bone and the tissue can expand, but most of the times they'll come out through the buccal, and infections are basically pretty lazy. They're going to take the easiest way to expand and erode bone. And in upper molars, they can easily go into the sinus. We'll see how that can become an issue as well. However, oftentimes they just break out through the buccal plate, basically not involving the sinuses and being a very localized infection. In mandibular cases, we have some more concerns because the infections can break through, and this is the lingual surface here, into the floor of the mouth. And the floor of the mouth is a very open, a very loose area. And so the infection can spread very quickly across from one side to the other, elevating the tongue, which is a key clinical sign as we talk about determining if the infection is moderate or severe. But once the tongue is elevated, it's pushed back. It can then easily compromise the airway, and that can cause an acute loss of airway and respiratory arrest for the patient. So some of these may be more subtle when we actually see the patient. And I think in our knee-jerk reflex to treat these patients, and naturally, as I mentioned earlier, try and get them out of our office and on their way and back into our scheduled time, an easy way often to do that is say, well, let me put you on this antibiotic and we'll get you back. Well, in most cases, truly antibiotics are not really necessary, and perhaps, as we'll see, may be causing more harm to the patient than potential benefit. So if you have something like this, a primary tooth with a draining sinus tract, which is spontaneously draining on its own, the child may have minimal to no pain, although it looks indeed like there's some infection that's draining. It does not necessarily indicate that the patient needs an antibiotic and that the body is basically taking care of the infection, allowing it to drain. And until we deal with the dental situation, whether we extract the tooth or perform a pulpotomy or other procedure, the infection really will not resolve. And we know that, of course, giving an antibiotic may cause the sinus tract to resolve temporarily. Obviously, it does not cure the problem. And again, not only as we talk about antibiotic side effects, sometimes it may give a false sense of a positive outcome to the patient or the parent that the problem is now cured by the antibiotic and that definitive treatment is not necessarily needed. So again, limited localized infections such as this, especially if they're draining with minimal pain, except perhaps to percussion or chewing, do not need antibiotic management. Now, when we get to diagnosing or determining if the infection is more serious, first thing we'll look at trismus. So we're always going to take a look in the patient, ask them to open their mouth, and that's a common thing that we all do in our dental practices. And if the patient can't open because of the infection, that means the infection is spreading through the muscle areas. We know there's the fascia or the lining tissue that covers the muscle, and as the muscles expand and contract, they glide along the internal aspects of the fascia. When the area gets infected and inflamed, the fascia now binds to the muscle itself so that the patient cannot open their mouth or perhaps move some other function. So trismus or lack of ability to open is a significant sign. We always want to ask the patient, do you have any difficulty in swallowing? And in severe cases, the patients are not managing their own secretions. So we all naturally produce an amount of saliva all day long, and we're normally swallowing it, so it's not drooling out of our mouth. Well, when someone has infection that's spreading back into the throat and the upper airway, it becomes extremely painful, so the patient does not want to swallow, and they're actually more comfortable letting the saliva just drool out of their mouth and manage it that way. So not managing their secretions is also a significant sign that this patient should be transported to a hospital emergency department for further evaluation. And again, as the infection descends into the throat and into the area of the vocal cords, patients will develop change in their voice. We use the phrase a hot potato voice. So it's like a very irritated, like they ate a hot potato and it's burned their vocal cords, and their voice starts to change as well too. So it's again a new patient. We don't know what their voice normally sounds like, but usually they'll come in with someone else because they're feeling so ill and in significant discomfort. And we can ask them, does their voice sound the same or is it changed? And they say they have voice changes again. That's a sign that I would like to get this patient into a hospital and have a CT scan or CAT scan done to determine the areas of involvement of the infection. Now here's obviously someone who's very sick and he has a positive sign, which is the hospital bonnet on already on his head. He gave us permission to use his picture, but you can see that he is physically sick looking. And again, it doesn't take a lot of diagnosis to determine that, although the infection is fairly significant on his left side, and it's extending not only from the masseteric region, the masseter muscle and the side of his face, but going across here under the submental region and going across to the other side. So the infections spread. Sometimes they go quickly where you'll see the cellulitis or the redness, and you can see some of the redness on the outside of the skin here. When you push on it, it will blanch. And that is an indication that it's a cellulitic type of a spread. Now, as this patient has been dealing with this infection for the last few days, they start to get feverish. And when we run a fever, our heart rate will increase. We also tend to lose a lot more fluid, so we become dehydrated. And so they're kind of cold, clammy skin, and they overall feel very poorly or very weak. So again, this is someone that should they present in your office, you would want to then refer directly to the hospital emergency department. So significant pain is usually the heralding sign that gets the patient into our offices. We know that a single tooth can become very, very acutely painful with an endodontic problem, and we can alleviate that pain if we can open up the tooth perhaps and do a pulpotomy. But what concerns us more, of course, is the spreading of the infection, and again, limitation of function and movement is some of the issues. Now, many of these infections that I just shown are actually, being an oral surgeon, have been secondary to pericoronitis or the infection in the gum over a third molar region. We know what occurs is that the gingival tissue does not attach to the enamel part of the tooth. It creates a space in here where food and bacteria gets in here and gets caught. And again, it's very tempting to look at a case like this and say, I'll start you on some antibiotics and refer you to an oral surgeon or make an arrangement to take out the tooth and get the infection under control. And we'll talk a little bit about how we deal with getting patients anesthetized with local anesthetics when they have areas of acute infection and inflammation. So we know, again, also with moderate infections that are just starting, that if we can get in here and clean out that area, that using local measures perhaps can avoid the need for an antibiotic. We can irrigate underneath that. We can use chlorhexidine rinses, which will help reduce the bacterial load. We can give patients irrigating syringes that they can then take home and keep clean. And again, there's a knee-jerk response that we should definitely give an antibiotic to the patient, but they don't always need it. And again, here's a pericornitis, a little bit more mild in a younger person due to the eruption of her first molar. And you can see, although it's very painful and sore, again, she's opening wide, so we know there's not muscle involvement. Her tongue is flat at the floor of the mouth, so it's not being elevated. So again, this is definitely a more mild infection. Again, one that's very amenable to irrigation, starting on chlorhexidine rinses. And in most cases, as I say, we can avoid having to prescribe an antibiotic, which can create more problems for the patient than not. So going back to this patient, again, she didn't look real bad, not as bad as the sick guy that we saw at the hospital, but you see her face is swollen, and we did get a CAT scan for her at the hospital, and this is her airway. And her airway normally should be this dark area all open over here as well, too. So the infection that we can see clinically is on the outside of her face, which is this portion here on her CAT scan. What we can't see from her examination is what's going on inside of her mouth. And you see here, there's this dark abscess area here, as well as swelling relative to the opposite side. So draw a line right down the center. You can see on her right side, which is uninvolved, the tissues are nice and healthy. On the left side, there's the abscess cavity. There's this generalized edema. It's pushing on the airway, squeezing it over to her right side. And so this is a significant infection that, although she may not look real bad, she needs to go to the hospital and have incision and drainage and probably remove all the infected tooth on a fairly urgent basis. And this was her complaints that it hurt to open and she was not eating and drinking. And when you look inside the mouth, not only do you see the pericornitis around the tooth, but also the soft palate area is swollen and being pushed over as well too. So this is a multi-space infection. And that also would indicate as well that it's an infection that's more virulent. It's spreading through the various areas and involving other spaces than just a single space. And that again puts it into the category of moderate to potentially severe type of an infection. And if we could have looked in her mouth, because she couldn't open her mouth wide, we would have seen the swelling of the soft palate region. But if you are able to, in some of these patients, sneak a look in there, see if the floor of the mouth is elevated or not, feel underneath the tongue from one side to the other, feel if it's boggy, put a tongue blade in there, look back in their throat. Sometimes the uvula will be deviated to the opposite side. And again, the soft palate allows the infection to spread through here fairly quickly, makes it very difficult to swallow for the patient, and leads to a lot of the complaints of discomfort and difficulty swallowing. So again, serious infections involve serious spaces. This is a young child with a fairly large buccal space infection, and kids will often swell up very quickly and very rapidly. But the concerning part is not so much the massive swelling here, but it's the extension up here medially or along the side of the nose up into the area of the eye. If you compare the right eye with the patient's left eye, you can see that this area underneath the eye has been obliterated by the swelling. And as an examination that we would do on this patient, it would be to have them move their eyes in various directions to see if it's affecting the muscles, the extraocular muscles that move the eye around. Again, once it's up into this area involving the preseptal or the area around the eyelid region, again, that is a patient that should be more urgently referred for an evaluation that day, again, either by someone who treats these types of infections or go to the emergency department. And this is another patient that we treated with a fairly significant infection of his right side of his face, again, affecting the orbital area as well too, closing the eye, that would be one where it's extending through multiple spaces. But also, too, we can see the erythema, or the redness, is descending down into his chest as well, too. So his entire neck and area due to the cellulitis spread. So not only will the infection, this source of it was an upper second molar, go superiorly involved here, but it starts to break through, involve other spaces, come down here into the neck. And as we monitor the patients, we'll actually draw a line on them to determine, is the infection spreading? Is it getting worse? Or conversely, if it's improving. And he went, directly to the hospital. We operated him on that night. And even on the following morning, you can see just by doing the incision and drainage and taking out the offending tooth, we get nice initial resolution of the swelling. You can now see his eye here. And we had marked out the erythema, and you can see the resolution of the redness here. So urgent treatment. And the tendency is to think, okay, let's get this guy in, let's get him on IV antibiotics and get him taken care of. But the IV antibiotics, although important, especially when multiple spaces are involved, it's more importantly to treat the source and site of the infection by draining it as well as extracting the tooth if need be. Now, we all worry in our practice minds, and we've all read case reports of brain abscesses from dental infections, and yes, they can occur. We do know in particular the most typical spread, that if it is going to go intracranially, will be through the sinuses. So a maxillary tooth, whether it's the first or second molar, and both these teeth are obviously involved. You can see here breaking through the floor of the maxillary sinus, creating an air fluid level, the air level, the fluid level. This most likely represents purulence or pus in this area here. And as that infection spreads, it can go through and block the normal drainage of the sinus because they're all interconnected. So the maxillary sinus will then connect with the ethmoid sinus, which connects with the frontal sinus. And then the frontal sinuses, also these sinuses have direct attachments and opening intracranially that can allow infection and the spread from the sinus by eroding the bony walls, which are often very thin, and getting into the brain itself. And so this is someone who had an odontogenic infection of number 14, spread to the maxillary sinus up centrally. And then you can see on her CAT scan, it was actually a brain abscess that occurred. So this is very rare. This is something we all have seen a case or two, and maybe in our dental school days or seen in literature, typically associated with a compromised host. Someone with severe uncontrolled diabetes is a classic situation that can present with this. And it's unlikely that should we be managing patients and following our patients that we'll ever get to this point. But again, this is always the thing that's hanging over our heads that concerns us a little bit as we start thinking about treating patients who have infections. So I want to talk about management, because that's why we are in our practices. We treat patients, we care for them. Obviously, we want to prevent dental disease, but when patients neglect that on their own and present to our practices with the signs of an acute infection, again, we do have the skills and responsibility to take care of that for them. And so I'd like to get us away from this thought process of immediately just writing a prescription for an antibiotic, but treating the source. And we may have to do an incision and drainage. We'll talk a little bit about doing those, and they can be extremely beneficial as far as alleviating the pain. Most of the pain with these acute infections is the pressure in the space, and you can imagine filling up an area with fluid and other inflammatory elements that's not meant to be, is putting a lot of pressure, and all those nerve endings are hypersensitized. And by draining it, the pus will typically spontaneously come out, oftentimes under significant pressure, and patients will feel fairly good and immediate relief. Now, we haven't cured their problem, right? They still have the endodontically involved or non-restorable tooth, but we've got them on their way to improvement. And if we can do an incision and drainage, and then secondarily perform definitive dental treatment for the patient, again, most of these cases don't require antibiotic treatment, although perhaps we'll be more likely then to prescribe an antibiotic because of certain medical legal issues as well. And if the patient were not to get better, we're always concerned that, well, if I've given an antibiotic as well as done the IND, perhaps they would have turned the corner a little sooner. So again, I'm not going to the soapbox and say that I don't prescribe an antibiotic for many of these cases, but I try and be judicious about it. And if I have a cooperative patient, I'm identified the source, I'm managing the infection, and most of the times an antibiotic is not really necessary. Now, the other issue, of course, is, getting profound local anesthetic effects for these patients. So we are going to do a surgical procedure, and whether going to start endodontic treatment or do an incision and drainage. We all know when there's swelling and inflammation in the area, it's much more difficult for us to anesthetize the area. And I would recommend, if you have further interest in this area, I did a program for Viva Learning on the lip is numb, but the tooth is not, and a situation that we've all faced in our dental practices. And I'm not immune to it either. I had one last week, and I give multiple injections of local anesthetic, even though they had profound lip and tongue signs with their inferior nerve block. And we'll talk a little bit about why that occurs as well, too. Now, the simple answer is that, we tell ourselves, and we can explain to the patients, and it's good explanation from the patient perspective, is that when you have an area of infection, it makes the area more acidic. So we know that normal tissue pH is about 7.4. And when we inject a local anesthetic solution, it's going to dissociate to the charged and uncharged form. And remember, it's the uncharged form that will work its way through the nerve membrane, which is primarily lipids. So it can't be charged, which is water soluble, but it has to be the uncharged or lipid soluble formulation. Once it gets inside the nerve membrane, it's going to dissociate again to that same 75-25 ratio. So in this example here, using a typical local anesthetic like lidocaine, which has a pKa of 7.9, means that if you inject 100 molecules of lidocaine, it's going to dissociate to a 75-25 ratio. 25 of those molecules out of the 100 can now pass through the nerve membrane. Once it gets inside the nerve membrane, it's going to redissociate to that 75-25 ratio. And it's actually the charge form that actually does block the nerve conduction. So you can see about 18 out of those 100 initial molecules are now available to block nerve conduction. Now, certainly as the local anesthetic diffuses through the nerve membrane, the equation will further shift and more molecules will come through. But then we have the issue of the local anesthetic now being reuptake and diffusing out of the nerve membrane and then losing the effect of it. But basically, it's a simple situation to look at and diagrammatically. So 7.4 is normal tissue pH, and we think that the pKa of lidocaine being 7.9 is pretty close. But when you deal with logarithmic numbers, a small change in a decimal position will definitely affect the amount. And so the closer that the pKa is to 7.4, the more of a 50-50 split that you will get between the charged and uncharged molecules. Now, when we talk about infected tissues, we'll say, okay, the area is more acidic due to the mediators of infection. And again, the body, though, is pretty good at buffering. But in this example, if the tissue pH were to drop to about 6, now instead of 100 molecules, we'll use the example of 1,000 molecules. But due to the fact that the pH is lower, it shifts the equation to the left. So only 10 of those first 1,000 molecules are available to form into the uncharged form, diffuse through that nerve membrane. Once it gets inside the nerve itself, the pH is going to be well controlled. So that's going to be renormalized at 7.4. And now you can see there's about 7.5 out of those 1,000 molecules that are now available to block nerve conduction. And that's a fairly simplistic way. And again, I will use that to my patients and say, the area is infected, it becomes more acidic. The acid counteracts the effect of the local anesthetic or Novocaine. So it's more difficult to get you numb. And so therefore, we may just want to do, for example, today, drain the infection, let the infection resolve. In reality, it's much more complicated than this. We know that if tooth number 30 has a localized infection around it, and we're giving a nerve block that's 5 centimeters away from that site, it's unlikely that the tissue pH has changed. But again, we'll see these situations where we just can't get profound local anesthetic. And the issue is that not only does infection create a lower pH locally, but it does change the receptors inside the nerve membrane to the local anesthetics and make them bind not quite as significantly well. So we do lose some of that effect as well. And it's, again, a lot more complicated than just the pH dropping, but it's, again, a good way to look at it. So what do we do? How do we compensate for this? So first of all, using a higher concentration of a local anesthetic. So we know our classic lidocaine is 2% solution. If we use 4% articaine, now we're getting twice as many molecules per cc. That can certainly help us in our regard of getting more profound local anesthetic. As I mentioned, when the local anesthetic diffuses through the nerve membrane, it's also going to start diffusing out because local anesthetics are reversible. Now, we want patients to be numb for a certain prescribed time to allow us to complete our care. If we're doing surgery, we may want it to linger for a little bit longer so they have postoperative pain relief until they can take some analgesics like nonsteroidals or acetaminophen. Articaine and bupivacaine are two agents, though, that are much highly protein bound. So they stick to the tissue proteins much better, particularly inside the nerve membrane, and therefore they can maintain their position there and work to continue to give you nerve blockade. And again, the closer the pKa is to the tissue pH, so again, normal pH is 7.4, lidocaine has a pKa of 7.9, articaine has a pKa of 7.8. Again, it doesn't sound dramatically different, but it will be a little bit faster onset than lidocaine, which has a higher pKa. This is something put out by one of the dental providers, suppliers rather, and you can see that the comparison with protein binding, the 95% articaine versus 65% lidocaine. The other issue is that articaine is much more lipid soluble. So it will cross those nerve membranes much more easily. And again, once it gets inside the nerve membrane, it's going to stick there very quickly and hang around for us. So it gives us a little bit longer duration. So we're not having the local anesthetic wearing off as soon as it's ongoing. So that may work out as well. Another aspect about articaine is that although they're both lidocaine and articaine are both amide local anesthetics, articaine is also metabolized in the blood by plasma cholinesterase. And so most amide local anesthetics like lidocaine are conjugated in the liver and require hepatic metabolism, whereas articaine does not rely on that to inactivate it. So it may be safer for its use in individuals who have pre-existing hepatic or liver disease. Now, we can also choose other options for the patient. We can use nitrous oxide, we can use inhalational or intravenous anesthesia. And again, these are adjuncts that we can add into our local anesthetic techniques to improve the patient experience to reduce the pain that they have. Let's go back to this minor, more localized infection. Again, something that we should all be comfortable treating in our office. Again, the source is tooth number 9, the upper left central incisor. You can see it's a little dark and discolored, so an endodontic issue. And basically, doing a small incision and drainage, the pus will drain spontaneously and basically by gravity. But doing just this little bit of incision here will significantly alleviate the pain and discomfort, irrigate it out, and give the patient 3 to 5 days for recovery, and the infection will have resolved, and now they can be treated more definitively with conventional care, utilizing local anesthetic solutions, and I would expect a very high likelihood of successful local anesthetic use. As I mentioned, when I'm treating areas of infection or cases where it's difficult to get numb, we'll routinely use articaine as our local anesthetic solution for those reasons mentioned earlier. And this was an article that came out in JADA last year. Basically, you can see that your probability of success with an inferior alveolar nerve block is 73% if you use articaine, and drops down to about 57% if we're using lidocaine. So again, there is some issues of the increased lipid solubility of the articaine molecule. I also feel the fact that you're using a 4% solution, giving you twice as many local anesthetic molecules, will certainly improve potentially your outcome. You can see mepivacaine at 3% is probably not a bad option as well too if you wish to use it. Now, one of the concerns that I'll hear from people is that the use of articaine has been anecdotally discussed long-term paresthesias. And the incidence is very, very low. First off, when you read the package insert for articaine, it is approved by the FDA for nerve block injections, so it's not a contraindication to its use, using it for a nerve block. You can see that prolonged anesthesia following a local anesthetic injection can occur with any of the different solutions. It's thought to be a little bit more associated with the higher concentration solutions such as articaine and prilocaine, but mepivacaine is 3% and it's probably one of the least likely to cause it. So again, we're not sure whether it's direct needle trauma to the nerve, whether it's the specific neurotoxicity of the different local anesthetic agents that causes the difference. I think the one article and follow-up from the Canadian reports back in 1990s, basically showing a fairly high incidence associated with articaine, which is a number that's greatly higher incidence than what's reported in most all the other literature that I've looked at. So one could, be facetious and say don't get an articaine injection in Ontario, but otherwise it's probably okay to use as a nerve block, anywhere else. And so I would recommend that you consider articaine as one of your primary local anesthetic solutions if you're not already utilizing it in your practice. And being an oral surgeon, we would get a call once a year from our various dental referrals where they've gotten a prolonged paresthesia, and it's not typically from articaine, but it's from lidocaine or other agents that they're using. So again, a very rare, very infrequent event occurring. And so it's very hard to give you very direct guidance on that. But I can tell you that the literature would support its use, and it definitely is approved for a nerve block should you choose to use. And then the other interesting thing is that as you look in other countries, particularly European countries that first used articaine before it was available here in the US, you can see that their market share of articaine is dramatically higher than the other local anesthetics. And they have access to lidocaine and bupivacaine and everything else, as do we. So I think there's a lot of literature out there. The Germans that I've spoken with that practice dentistry and oral surgery, they use articaine as their normal agent for nerve blocks, local infiltrations, and they've all felt that there's not been a significant increase or dramatic problem occurring with its use in their practices. Now, the other issue when we're dealing with infections is to think about draining infections. So why do we put in a drain? Basically, a drain is placed in there to maintain the opening that we've created with our surgical incision. The pus itself typically doesn't come through the tube itself, but around it, and it's not critical that the pus comes through it. It does allow us to irrigate and get access. And, my thoughts are I'll use a drain more frequently when I can't get dependent drainage occurring. So in this situation, it's nice to see, and it's well illustrated, placing a maxillary drain. But again, probably one that's not necessary because patients are fairly upright or head is elevated. And so you're going to get gravity draining the area. When we have multiple spaces involved, some of those cases I showed you earlier that need to go to the hospital and have their care taken care of, then we'll place drains into the various areas to make sure that the infection can come out, and then we can also irrigate it and dilute the agents in there, making sure we're keeping patency so that the pressure can be alleviated for the patient and they can resolve their infection. So probably the most important thing to talk about is antibiotic utilization. And again, it's a nice way to wrap up an appointment with a patient. You write a prescription and tell them go home, start these antibiotics, and they'll probably feel better. And in most cases, they will. However, if we can provide some surgical intervention, whether it's just a simple IND or what have you, that's going to actually be much more important and much more effective than throwing the right antibiotic out at a patient. But patients do sometimes need antibiotics, and again, we do utilize them as well. I'm not going to say we don't. The first line of drug, we always want to think of amoxicillin or penicillin. They're very, very effective in odontogenic infections. They have low toxicity. They're very low cost. Probably the issue becomes with allergies. And interesting with penicillin allergy, actually, there's a National Penicillin Allergy Day on September 28th. So if anyone wants to send me a Hallmark card on that day, I'm not allergic, but my daughter is. But interestingly, on antibiotic allergies, is that 90% of the people who say they're allergic to penicillin are not really allergic. And actually, only 1% of people are. So it's actually a rare occurrence. A lot of times it's a misdiagnosis, something they were told about when they were young. They carry that for the rest of their lives. Sometimes they'll say, my parent is allergic to penicillin, so I don't want my child to have penicillin because they might be allergic. And again, those are not really good indications because we know everything else after amoxicillin and penicillin is going to be not as effective with a much higher incidence of side effects. Interestingly as well, that after 10 years or so, people can actually outgrow an allergy to penicillin. So again, we're not in the allergy testing business. It's not part of my practice, and I don't think part of yours as well too. If you have a patient that has an allergy and we have the time and luxury to get them evaluated, they don't do skin testing anymore. They actually will do a penicillin challenge. So they'll go to an allergist, they give them a very low dose of amoxicillin, have them sit around for 30 minutes. If they have no side effects, they give them a full therapeutic dose based on their weight, and then have them sit around for 2 hours and observe them at that point. So that's the way penicillin allergies testing is done nowadays. No more pinpricks and things such as that. So it may be a consideration. It was interestingly on this area, as we talk about giving antibiotics prophylactically or to prevent infections, an example might be with implant patients. NYU just published a study last week, and they had a 17% failure rate of implants in patients that were penicillin allergic, and an 8% failure rate in patients who are not penicillin allergic. So I felt, and probably most of us would feel, that an 8% failure rate is still relatively high, that our success rate should be higher than that. But at least it was interesting in their patient population that those that did not take amoxicillin for their antibiotic prophylaxis had a higher failure rate as well. Clindamycin now is always our first-line alternative for the penicillin allergic patient. I do want you to consider eliminating that from your practice. The side effects of the pseudomembranous colitis due to superinfection of C. difficile is very, very significant. It can affect young, healthy individuals. It can affect older people who are much more likely to have severe morbidity and mortality from that. But there are plenty of cases of 17, 18-year-olds taking clindamycin, developing C. diff, having to undergo colon resections and other significant follow-up and management. So we do want to black box that in our practice. It's a great antibiotic for our needs, and it was a good choice when we had a true penicillin allergic patient. But now we switch to azithromycin for our penicillin allergic patients. The drawback is it's not going to be as effective as clindamycin, and certainly neither of those are as effective as amoxicillin or penicillin are. But again, consider eliminating that from your regimen. Now, should you elect to give a patient an antibiotic, there are 6 possible things that can occur once they start taking an antibiotic. They may develop an allergy, which is obviously a negative thing. They may develop toxicity. Penicillin and amoxicillin have a fair amount of potassium, and so that can actually affect their electrolyte levels. They can develop a super infection with resistant bacteria, and this is, again, why we need to be good stewards of antibiotics to only prescribe them when absolutely necessary. But we know knocking out normal bacteria that occupy receptor sites in our bodies, and we're all a walking biome of millions and billions of different bacteria. And once you start giving an antibiotic, you open up these receptor sites to other bacteria that may be resistant to your antibiotic, and then occurring a secondary infection. And again, the C. difficile, Clostridium difficile is a prime example of that. The bacteria themselves can be pushed to develop chromosomal mutations and develop resistance to the antibiotics. And that's our big concern, that they're going to get out there. We're going to have the superbugs, as we hear about every once in a while, that are not sensitive to any of our antibiotics, and patients have significant issues fighting those infections off. So again, chromosomal mutations are random events when they occur. And if you give enough antibiotics to enough people, then we're going to mutate to resistant forms. And some of these bacteria as well have dormant resistance that's programmed into their DNA or RNA. And then all of a sudden, when we start giving antibiotics, it allows these things to develop. So those are 5. And so out of the 6th thing, there's only one positive aspect, and that's the host's immune system gains control and eliminates the infection. And again, antibiotics in themselves don't cure infections. They basically facilitate the host, excuse me, to eliminate the bacteria themselves. And again, in conjunction with our care, whether it's surgical or endodontic care of the patient to eliminate the source infection, it's what's going to get the patient well. And again, this is the only positive out of the 6 things that can possibly occur when you give an antibiotic. So again, the key point is infections are cured by the host, limiting the source of the infection. The normal white blood cells and other agents get in there and fight off the infection. Again, we may want to consider an antibiotic when the host is overwhelmed, so the infection is spreading. We're getting the cellulitis, the descending infection. The infection is spreading from the vestibular space to the buccal space to the canine space, or if the patient has impaired host defenses. So certain individuals, say severe diabetics whose blood sugars are out of control, that creates a great medium for bacteria to grow and allows then the bacteria to take over. And so again, in conjunction with surgery, we need antibiotics as well too. So again, host defense impairment may be physiologic, certain diseases, maybe drug suppression, and some people just have a defective immune system. So again, they'll give you this in their health history, and they may push you a little bit more to be concerned about giving an antibiotic to this individual. Now, sometimes we start treating a patient and they don't get better, and we've prescribed an antibiotic, maybe we've done a small incision and drainage, and the patient is getting worse, so they're calling us up about that. So first off, need to verify we have the correct source. Maybe it's more than one tooth, and there's another tooth in the area that's still involved. Verify that we're in the drainage, that we're draining the correct spaces to allowing then blood circulation, because as that pressure, it decreases blood flow. So no matter how much antibiotic you give the patient, whether it's IV or orally or PO, it can't get to the site to become effective. We can consider adding a second antibiotic, and the one I would consider adding, especially with odontogenic or tooth infections, is Flagyl or metronidazole. It's going to give us a little bit more coverage for the anaerobes. And we find that combination of penicillin, amoxicillin with the Flagyl to be very effective, especially as we're seeing resistance to other antibiotics that we use. And then certainly if the patient's not getting better in 24 hours and it's getting a little bit beyond your level of comfort or the patient's comfort, then again, sending the patient to someone who deals with the infection, whether it's an oral surgeon or your hospital emergency department, is not a sign of weakness. Not everybody gets better. Sometimes we'll see infections following surgery. So if you place some implants or you've taken out some teeth and the patient develops a secondary infection, some of those can get pretty severe. And so again, you may want to consider referring if they're not getting better. Now, one of the thoughts we always think about with antibiotics are the bactericidal that actually kill the bacteria versus bacteriostatic that prevent them from growing. There's a thought process that bactericidal antibiotics are going to be much better for the patient because they actually kill off the bacteria. But again, we can use azithromycin. We can also consider the sulfonamides. Again, some patients will tell you they have a sulfur allergy, which means that they're allergic to sulfonamides, and often used in women for urinary tract infections. And so those are fairly bona fide responses, and it does not mean there's a cross allergy to the antibiotics such as amoxicillin and penicillin. So when do you really need to use a bactericidal that actually kills bacteria? Those are when you have impaired host defenses. So the host himself can't get in there very well. The white blood cells are not functioning. Patient maybe has very low white count due to being on chemotherapy or something like that. Then we want to go more to the cidal type antibiotics. But bacteriostatic are actually good antibiotics for most patients. And actually they have post-antibiotic effects. So this bacterial suppression of growth is longer and more reliable, and it's less dose or time of day dependent. So these hang around a little bit longer in the system. They actually prevent bacterial growth. So therefore the body now can get in there with the white blood cells and start phagocytizing them and cleaning them up and getting better. Again, if the patient's not getting better after a day or two, or certainly getting any worse, we can consider getting cultures. I can tell you through my years of dealing with fairly significant infections that come into our hospital, cultures rarely, if ever, have guided our course of antibiotics. What has cured the patient is draining the patient and treating the infected teeth. But again, if the patient's not getting better and they're on antibiotics, you could consider doing a culture. If it's a postoperative wound infection, especially if the patient had come from the hospital. So the patient was in the hospital maybe with a traumatic injury, now comes to us with some other type of odontogenic infection, you're concerned they have some unusual bug that they picked up in a hospital setting. And if they have infection of the bone, such as osteomyelitis, again, we may want to get an antibiotic culture at that time. But again, it's unlikely it's going to really change much about practice and choice of antibiotic. Again, giving more higher doses of antibiotics doesn't really help. basically that they're set to give it a high enough dose, what's called the minimum MIC, or the minimum inhibitory concentration, so that the bacteria are not growing, or else they're having the sidal effect of using amoxicillin. So putting it kind of all together, I would recommend amoxicillin or penicillin to start. PENVK, again, very, very well tolerated antibiotics. Try and convince your patients who give you a history of allergy to describe exactly what their allergy was, see if it's a bona fide thing. If it's just because their parent is allergic or their cousin's allergic or what have you, again, they can take it. And again, it's a little bit concerning if they've had a major anaphylactic type reaction. Of course, we would not give them any penicillin, but a little rash or a little itching may have been related to something else. If the penicillin is not effective, then we can add the metronidazole flagyl within 24 hours, and that will give us a broader coverage. And again, going back and making sure, again, we have the right source, the right tooth, and that we are draining the infection. Augmentin can be used. It's amoxicillin with clavulanic acid. It's going to increase some broader spectrum of coverage, but that clavulanic acid is very irritating to the patient. So patients come to us and say, oh, I'm allergic to penicillin. It really, what kind of allergy do you have? Well, I took this one and it really made me sick to my stomach. And then if you drill down further, and it turns out they were on augmentin, it's the clavulanic acid. So they do have to take that with food. And there are a lot of patients that just don't tolerate that very well. Zithromycin, again, we're going to be replacing clindamycin in our practices with zithromycin. 500 milligrams once a day is a good dose. Again, that also will irritate some people's stomach. And again, you're not going to get as good a coverage of bacteria as you would with a penicillin such as amoxicillin, but it's going to be our second choice. And then Levaquin, the fluoroquinolones, a little bit less specific for odontogenic infections, but they do work. And occasionally around implants, they seem to have a little bit higher improvement. So if someone got an infection following an implant or has a bone plate in their jaw from trauma or things like that, sometimes those antibiotics can be utilized as well too. So again, response to an antibiotic will take about 2 days. The key thing is we want them to be improving within 24 hours. If they're not improving or getting worse, then we need to look at step 2, which may be to add the flagyl or to make sure we have the right source. If patients feel better, but again, if there's a failure of an antibiotic, they're no better or a little worse, that is a huge warning sign for us. And that, again, we just can't say, well, let's give it another day or two, but we should, again, take that as bona fide information from the patient and then maybe decide to refer or change your course of treatment, for that individual. Duration of dose is always a thing as well. If you take out the tooth and they're on antibiotics for that, 2 days is plenty of time for everything to resolve. We don't have to do 7 days or a full week. The thought being that there's some lingering bacteria or resistant bacteria is not really true. So get the patients on the antibiotics appropriately if you need to, and get them off just as quickly. Again, if we're using it prophylactically, say for an implant case, give a dose before the surgery, because after the surgery does not have any protective benefit for the patient. And typically within 24 hours, you can stop the antibiotic as well too. That continuing for longer, that time does not really help them. So you do the endodontic procedure, you take out the tooth that's infected, and they're on antibiotics. Within a day or two, they can definitely stop it. So why do antibiotics not work? Typically, it's inadequate surgical or dental treatment. Perhaps it's depressed host defenses, not pretty common. Maybe foreign bodies in there as well, and that's more common with traumatic injuries where patients have road debris and things like that that were not really cleaned out. Yeah, it could be an antibiotic issue that the bacteria is particularly resistant, but again, I will say that from odontogenic infections, we cure the infection, not the antibiotic, and that the drug may not be reaching in the dose or it may be a wrong antibiotic. I mentioned a little bit that if you are going to give a prophylactic antibiotic, and speaking in this terminology of before the surgery is started, we have to, first of all, make sure that there's a risk of infection that must be significant. What we do in the oral cavity is what's called clean contaminated surgery. So they're going to make an incision and place an implant in tooth number 30. That's clean contaminated surgery. The general surgery infection rate for that is felt to be about 3 to 5%. But what is the consequence? It's much more significant if somebody opens up my belly and I develop an intra-abdominal abscess. than if I do develop a secondary infection from a dental extraction. So we can treat these locally inside the mouth by irrigation with topical agents such as chlorhexidine, where we don't have to always rush to using an antibiotic. If you are going to give an antibiotic, you must pick the one that's going to fight oral bacteria. So again, the penicillins are going to be the choice. It must be high, and it must be timed correctly. And timing is all about that. It has to be in the system prior to your incision. So if you place 2 implants and you hand the patient a prescription for some amoxicillin as they're leaving, that's not really going to prevent infection, and your rate of infection is going to be the same as if you gave them no antibiotic at all, but you have the risk of all the side effects that can occur with an antibiotic. So again, take the antibiotic before the surgery, so it's in the system, so an hour ahead of time. If you're doing it orally or IV, obviously you'll get immediately into the system from as well. But for most of our cases, post-operative, we're handing someone an antibiotic on the way out the door doesn't help. So again, these are the types of surgical procedures that have a low incidence of infection, that standard tooth extraction, including impacted third molars. And there's been a number of studies that really fail to really justify routine antibiotic use for third molar impaction surgery. In our practice, we'll place topical antibiotics into the extraction site. We use doxycycline, and we've looked at our infection rate to be around, for full bony impacted teeth, to be under 1.1%. So the chance of that occurring is very low. So again, we can treat the infections should they occur without the risk of antibiotic side effects. Very long duration of surgery, notice to increase infection, so you may want to give an antibiotic in that situation. So if you're doing extracting 20 teeth and putting in 8 or 10 implants, there we have a long procedure that you may want to consider antibiotics. And as I mentioned earlier, there are some studies showing that antibiotics with dental implants seem to improve success outcomes as long as it's a penicillin. Again, duration, you want to have it half the therapeutic time. So you're going to dose a little bit more frequently for a longer procedure, but the key thing is for prophylaxis, we can stop it at closure and go from there. So including in this of antibiotic therapy, the antibiotics don't really cure patients. They're not really a substitute for dental procedures or surgery. It doesn't really matter necessarily which antibiotic to use as long as we're treating the patient surgically and dentally. Antibiotics do not really improve the host's defense to infection, so it just helps infection in that area. Multiple antibiotics are not necessarily superior to one, in that we know with dental infections, there's probably 6 to 12 different bacteria that can be cultured from the pus if you use careful technique. But we don't need to kill all 12 of those bacteria to get the patient to resolve. So they can heal up and do well just by eliminating some of it, and again, most importantly, dealing with the surgical problem. As I mentioned, that cidal antibiotics are not necessarily superior to bacteriostatic ones. So again, that should not be driving your choice. And most importantly, that we really don't know what are the best antibiotics, what best dose intervals, and what durations. These are not really well established. So the randomized clinical trials have not really been done. There are some anecdotal data out there, but again, if we can eliminate the source of the infection, we can eliminate the antibiotic and the patient will recover just as well. And again, I urge you to get the patients on the antibiotic quickly if you need it, and get them off just as quickly once you've treated the patient dentally. So at this point, I'm going to turn it back over to our host. We will stop and take some questions. So we have about 8 minutes left. I'll pull that up on here. And again, I want to thank everyone for their attendance and questions. So the first one is, how long will it take for pericoronitis to heal if we do in-office chlorhexidine, perhaps prescribe it at home nightly? So again, within the next day, they should start feeling better. And getting in there, usually there's a popcorn kernel or something stuck under that gingival flap. It may also be inflamed by the chewing of the upper third molar, which may be erupted directly into that pericoronal flap as well too. So sometimes taking out the upper third molar will alleviate the pain, just irrigating, cleaning it out. And again, the patient should feel better the next day. If you call them or they call you and say, I'm not feeling any better, it's worse, I can't open my mouth now, that's a sign that they need to be referred for more urgent treatment. There's a question about antibiotics if they're allergic to penicillin. Again, I really want to make sure they are allergic before I give up on penicillin for them. And again, my dosing will be now azithromycin So I'll give them 500 milligrams a day of azithromycin. And then there's another question, a hypothetical question, which we all pretty much are, but if an antibiotic is prescribed to a patient who has no infection, does the patient develop resistance if there is no infection? So that's a good thought. Well, we all have this biome, and again, we're just made up. We're not made up of it, but bacteria, yeast, fungus, everything else is living in our body in basically a symbiotic relationship. And we need that. And we know that if we wipe out all the bacteria in the mouth, that's why we get candidiasis or thrush, because now those binding sites are available to the yeast or the fungi that can now bind where there were bacteria sitting there before. So I would suspect we would not necessarily create resistance, but we may create super infections with other more virulent and more pathogenic bacteria that can occur. Question about CE certificate. I forgot to mention about that. At the end, you'll be directed to fill out a form and answer a few questions, and then you'll get your CE for that. Now, another question. Did I hear correctly that you get the patient off the antibiotic as soon as possible? Does that mean they do not finish the full course of the antibiotic? Exactly. So again, I see a patient on Monday with a infected number 30. There's swelling in the vestibular area. I know I'm not going to be able to get them numb to extract that tooth. I might have to come back and have an IV anesthetic or get the infection under control so that my local anesthetic will be more profound. So I'll start them on penicillin if I can get them back on Wednesday and the infection is better and I can get profound local anesthetic and extract the tooth. I'll tell them, take your antibiotic today, Wednesday, your nighttime dose, and then stop it. We've gotten the tooth out, we've drained the infection, and take the rest of those antibiotics and throw them away. Of course, there's a tendency with individuals that keep everything in their medicine cabinet, but that's always an issue. And then a very important question, what is a safe local anesthetic to use on pregnant patient that has clearance for treatment? So pregnant patients, we always think about as treating them in their second trimester as being the most ideal time to treat them. There are some concerns in the OBs with the use of the epinephrine. So epinephrine is an important component. So sometimes people will go with bupivacaine plain. Again, as I mentioned earlier, that articaine is a great adjunct because it has the metabolism by the plasmacholinesterase. So therefore, it's more immediately broken down and more rapidly broken down in the bloodstream to inactive form. So from that aspect, I would say that any of those would be efficient. I think you should consider a consultation with the patient's obstetrician to be sure with that. Next question about an allergy to sulfa drugs. Do you still use lidocaine? Yes. So sulfonamides, which are the antibiotics like Bactrim and things such as that, the trade names, do cause allergens, and but we can still use lidocaine with those patients as well. And then a question about cefazolin in a penicillin allergic patient. So the cephalosporins, whether it's Keflex, Ceftin, and the other ones, is also felt to be safe to be given to a penicillin allergic patient. So there are just some people that are overly sensitive and they react supposedly to many different agents. And when I get a patient comes in and tells me I'm allergic to this, I'm allergic to that, I say, well, I need to know, in case I have to give you an antibiotic, what can you take? So I'd rather sometimes ask the opposite question, not what are you allergic to, but what can you take? And that sometimes give us some information. So that's hard to deal with, but there's not proven cross-reactivity. I would warn the patient a little bit about that, that they might have a reaction to it. But again, oral antibiotics are very, very unlikely, if ever, to create an anaphylactic reaction. And then I'll just take the last question about, can repeat the point about clindamycin use. So clindamycin, again, like any antibiotic, will knock out a lot of bacteria in our system. In our GI tract and our gut, we have a lot of host bacteria that live there that are important for us to live because they allow us to absorb nutrients like vitamin K and other agents. And when we take clindamycin, we knock those out. But what we don't knock out is the Clostridium difficile, and that allows that bacteria, if it's exposed or if the host is exposed to it, to start growing very rapidly in the gastrointestinal system and creates a very severe colitis. And that can be fatal. That again, I have seen cases of young people, young, healthy 16-year-olds that had to have colon resections that'll be a lifetime of aggravation for that individual. Other individuals have gone through long-term antibiotic treatment, and in fact, fecal transplants are often used to try and reestablish a normal biome for these patients. So again, antibiotics in most cases, just like anything else, are unlikely to cause trouble for us, but we certainly can create problems. And if we can avoid the antibiotic, then I would recommend doing that. So we drain the infection, treat the tooth, do the endo, get out the tooth, we can stop the antibiotic that day. So right at the hour here, I want to thank all for their attendance. I want to thank Burrell Pharma, the manufacturers of Orablock, a formulation of Articaine, for their sponsorship of this program and for your continuing education. My email address is up there, and feel free to reach out to me directly if I can answer or clarify anything you said. Thank you all. Be well. Take care.